1101 environmental factors, 1102 mechanisms of cell destruction, 1102 pathogenesis of type 2 diabetes, 1103 genetic factors, 1103 environmental factors, 1103 metabolic defects in type 2 diabetes, 1104 monogenic forms of diabetes, 1105 genetic defects in beta cell function, 1105 genetic defects that impair tissue response to insulin, 1105 diabetes in pregnancy, 1105 clinical features of diabetes, 1106 the classic triad of diabetes, 1106 acute metabolic complications of diabetes, 1106 chronic complications of diabetes, 1107 morphology of chronic complications of diabetes, 1108 clinical manifestations of chronic diabetes, 1111 pancreatic neuroendocrine tumors, 1113 hyperinsulinism, insulinoma, 1113 Zollinger-Ellison syndrome, gastronoma, 1114 other rare pancreatic endocrine neoplasms, 1114 adrenal glands, 1114 adrenal cortex, 1115 adrenocortical hyperfunction, hyperadrenalism, 1115 hypercortisolism, Cushing syndrome, 1115 primary hyperaldosteronism, 1118 adrenogenital syndromes, 1120 adrenocortical insufficiency, 1122 primary acute adrenocortical insufficiency, 1122 Waterhouse-Friderichsen syndrome, 1122 primary chronic adrenocortical insufficiency, Addison disease, adrena 24 adrenocortical neoplasms, 1125 other adrenal lesions, 1126 adrenal medulla, 1126 pheochromocytoma, 1127 multiple endocrine neoplasia syndromes, 1129 multiple endocrine neoplasia type 1, 1129 multiple endocrine neoplasia type 2, 1130 pineal gland, 1130 pineloma, 1131. The endocrine system consists of a highly integrated and widely distributed group of organs called glands that orchestrate a state of metabolic equilibrium among the various organs of the body. Signaling by secreted molecules can be classified into three types: autocrine, paracrine, or endocrine, on the basis of the distance over which the signal acts. In endocrine signaling, the secreted molecules, also known as hormones, act on target cells that are distant from their sites of synthesis. An endocrine hormone is frequently carried by the blood from its site of release to its target. The production of several hormones from endocrine glands is stimulated by trophic factors released from the
system. Pituitary.
The endocrine hormone inhibits production of the trophic factors, a process known as feedback inhibition, thus maintaining physiologic levels of the hormone. Several processes can disturb the normal activity of the endocrine system, including impaired synthesis or release of hormones, abnormal interactions between hormones and their target tissues, and abnormal responses of target organs. Endocrine diseases can be generally classified as 1. Diseases of underproduction or overproduction of hormones and their resulting biochemical and clinical consequences, and 2. Diseases associated with the development of mass lesions. Such lesions might be non-functional, or they might be associated with overproduction or underproduction of hormones. The study of endocrine diseases requires integration of morphologic findings with biochemical measurements of the levels of hormones, their regulators, and other metabolites. Pituitary gland. The pituitary gland is a small bean-shaped structure that lies at the base of the brain within the sella turcica. Its function is controlled by the hypothalamus, to which it is connected by a stalk containing axons extending from the hypothalamus and a rich venous plexus. Along with the hypothalamus, the pituitary has a central role in regulating the function of most of the other endocrine glands. The pituitary gland is composed of two morphologically and functionally distinct components: the anterior lobe, adenohypophysis, and the posterior lobe, neurohypophysis. The anterior pituitary, or adenohypophysis, which constitutes about 80% of the gland, produces trophic hormones that stimulate the production of hormones from the thyroid, adrenal, and other glands. The anterior pituitary is composed of epithelial cells derived embryologically from the developing oral cavity. In routine histologic sections, it contains a colorful array of cells that variously have eosinophilic cytoplasm, acidophils, basophilic cytoplasm, basophils, or poorly staining cytoplasm, chromophobe cells. Detailed studies have demonstrated that the distinct staining properties of these cells are related to the presence of different polypeptide hormones within their cytoplasm that control the activity of other endocrine glands. There are 6 terminally differentiated cell types in the anterior pituitary, each of which is defined by the hormones that it synthesizes. Somatotrophs produce growth hormone, GH. Mammosomatotrophs produce GH and prolactin, PRL. Lactotrophs produce PRL. Corticotrophs produce adrenocorticotropic hormone, ACH, pro-opiomelanocortin, POMC, and melanocyte-stimulating hormone, MSH. Thyrotrophs produce thyroid-stimulating hormone, TSH. Gonadotrophs produce follicle-stimulating hormone, FSH, and luteinizing hormone, LH. In women, FSH stimulates the formation of Graafian follicles in the ovary, and LH induces ovulation and the formation of corpora lutea in the ovary. The same two hormones also regulate spermatogenesis and testosterone production in males. The production of most pituitary hormones is controlled by positively and negatively acting factors from the hypothalamus, figure 24.2, which are carried to the anterior pituitary by the portal venous plexus. While most hypothalamic factors promote pituitary hormone release, others, e.g., somatostatin and dopamine, are inhibitory. Rarely, signs and symptoms of pituitary disease may be caused by overproduction or underproduction of hypothalamic factors, rather than a primary pituitary abnormality. During embryogenesis, specific transcription factors regulate the differentiation of multipotent stem cells within the Rathke pouch into the various cell types of the anterior pituitary. For example, somatotrophs, mammosomatotrophs, lactotrophs, and thyrotrophs are all derived from a common precursor that expresses the transcription factor PIT-1. Lactotrophs also express the alpha subunit of the estrogen receptor, aralpha. By contrast, corticotrophs are derived from progenitor cells expressing the transcription factor TPIT, also known as T-box protein 19 or TBX19, and gonadotrophs are derived from precursor cells expressing steroidogenic factor -1 SF1 and GATA2. The expression of these lineage-specific transcription factors is retained in pituitary adenomas and is used to classify these tumors. See later. B figure 24.1 A photomicrograph of a normal pituitary. The gland is populated by several distinct cell populations containing a variety of stimulating tropic hormones. Each hormone has different staining characteristics, resulting in a mixture of cell types in routine histologic preparations. B. Immunostain for human growth hormone. Pituitary GL1D0N S67. TRH PIF dopamine CRH hypothalamus GRH GH resomatostatin GnRH stalk. Anterior posterior. TSH PRL ACTH pituitary GH FSH LH Figure 24.2 hormones released by the anterior pituitary. The adenohypophysis anterior pituitary releases 5 hormones that are in turn under the control of various stimulatory and inhibitory hypothalamic releasing factors. The stimulatory releasing factors are TRH thyrotropin releasing hormone, CRH corticotropin releasing hormone, GHRH growth hormone releasing hormone, and GnRH gonadotropin releasing hormone. The inhibitory hypothalamic influences comprise PIF prolactin inhibitory factor or dopamine and growth hormone release inhibiting hormone GHRE or somatostatin. TSH thyroid stimulating hormone thyrotropin PRL prolactin, ACH adrenocorticotropic hormone corticotropin, GH growth hormone somatotropin, FSH follicle stimulating hormone LH luteinizing hormone. The posterior pituitary consists of modified glial cells termed pituocytes and axonal processes extending from the hypothalamus through the pituitary stalk to the posterior lobe axon terminals. 2 peptide hormones are secreted from the posterior pituitary, oxytocin and antidiuretic hormone ADH, also called arginine vasopressin or AVP. These hormones are actually synthesized in the hypothalamus and are transported through axons to the posterior pituitary. In response to appropriate stimuli, the preformed hormones are then released directly into the systemic circulation. For example, dilation of the cervix in pregnancy results in oxytocin release, leading to contraction of the uterine smooth muscle, facilitating parturition uterine labor. Similarly, oxytocin released on nipple stimulation in the postnatal period acts on the smooth muscles surrounding the lactiferous ducts of the mammary glands and facilitates lactation. Synthetic oxytocin can be given to pregnant women to induce labor. The most important function of ADH is to conserve water by restricting diuresis during periods of dehydration and hypovolemia. Decreased blood pressure sensed by baroreceptors, pressure-sensing receptors in the cardiac atria and carotids, stimulates ADH release. An increase in plasma osmotic pressure detected by osmoreceptors also triggers ADH secretion. In contrast, states of hypervolemia and increased atrial distension result in inhibition of ADH secretion. Hyperpituitarism are discussed later in the context of individual tumors. Hypopituitarism results from deficiency of trophic hormones. It may be caused by ischemic injury, surgery or radiation, inflammatory disorders, and the mass effects of non-functional pituitary adenomas. Symptoms related to local mass effects. Because of the close proximity of the optic nerves and chiasm to the sella, expanding pituitary lesions often compress decussating fibers in the optic chiasm. This gives rise to visual field abnormalities, classically in the form of defects in both lateral, temporal visual fields, so-called bitemporal hemianopsia. Like any expanding intracranial mass, pituitary adenomas can produce signs and symptoms of elevated intracranial pressure, including headache, nausea, and vomiting. On occasion, acute hemorrhage into an adenoma is associated with clinical evidence of rapid enlargement of the lesion, a situation appropriately termed pituitary apoplexy. Acute pituitary apoplexy is a neurosurgical emergency because it can cause sudden death. See later. Diseases of the posterior pituitary often come to clinical attention because of increased or decreased secretion of ADH and associated changes in fluid and electrolyte balances. Clinical manifestations of pituitary disease, pituitary adenomas, and hyperpituitarism. The manifestations of pituitary disorders are related to either excess or deficiency of pituitary hormones or to mass effects. Hyperpituitarism arises from excess secretion of trophic hormones. The causes of hyperpituitarism include hyperplasias, adenomas, and carcinomas of the anterior pituitary, secretion of hormones by non-pituitary tumors, and certain hypothalamic disorders. The symptoms of. The most common cause of hyperpituitarism is an adenoma arising in the anterior lobe. Pituitary adenomas are classified on the basis of the hormones and cell type, specific transcription factors that are expressed by the tumor cells, table 24.1. Some pituitary adenomas secrete 2 hormones, GH and prolactin being the most common combination, and rarely, pituitary adenomas are plurihormonal. Less common causes of hyperpituitarism include pituitary carcinomas and 1068, Chapter 24, the Endocrine System, Tableau, adenoma type somatotroph adenoma, lactotroph adenoma, thyrotroph adenoma, corticotroph adenoma, gonadotroph adenoma. Classification of pituitone ir ammonidisacta. Hormone, GH, PRL in same cells, GH, PRL in different cells, PRL, GH, focal and variable, TS. ACH, FSH, LH. Null cell adenoma, plurihormonal adenoma anode. That non-functional silent adenomas in each category express the corresponding hormones and transcription factor within the neoplastic cells, as determined by special immunohistochemical staining on tissues. However, these adenomas do not produce the associated clinical syndrome and typically present with mass effects accompanied by hypopituitarism due to destruction of normal pituitary parenchyma. These features are particularly common with gonadotroph adenomas and up to 1/5 of corticotroph adenomas, while rarely observed with somatotroph or lactotroph adenomas. Null cell adenomas, by definition, only present with mass effects. ACTH, adrenocorticotropic hormone, FSH, follicle stimulating hormone, GH, growth hormone, LH, luteinizing hormone, PRL, prolactin, TH, thyroid stimulating hormone, partially. Modified from Lopes MBS, the 2017 World Health Organization classification of Stromatopho, AH, Eratutip, A24DA1G, SMemory, Neuropathol 452, 535, 2017, None, GH, PRL, TSH. None. PIT1, transcription factor, PIT1, or PIT1, PIT1, or PIT-1, or PIT-1, or PIT1, TPIT, SF1, GATA2, or alpha. Morphologic variant, densely granulated adenoma, sparsely granulated adenoma, mamosomatotrough, adenoma, mixed somatotroph, lactotroph, adenoma. Sparsely granulated adenoma, densely granulated adenoma, acidophilic stem cell adenoma, thyrotroph adenoma, densely granulated adenoma, sparsely granulated adenoma, Crooks cell adenoma. Prominent intracytoplasmic, cytokeratin filaments, gonadotroph adenoma, associated syndrome gigantism, children, acromegaly, adults, galactorrhea, and amenorrhea. In females, sexual dysfunction, infertility, hyperthyroidism, Cushing syndrome, Nelson syndrome, mass effects, 20% of corticotroph adenomas are hormonally silent. Mass effects and hypopituitarism. Most gonadotroph adenomas are hormonally silent, mass effects, some hypothalamic disorders. By contrast, large pituitary adenomas, and particularly non-functioning ones, may cause hypopituitarism by destroying the adjacent normal anterior pituitary parenchyma. Pituitary adenomas are usually found in adults. The peak incidence is from 35 to 60 years of age. They are designated, somewhat arbitrarily, microadenomas if they are less than 1 centimeter in diameter, and macroadenomas if they exceed 1 centimeter in diameter. Non-functional adenomas are likely to come to clinical attention at a later stage than those associated with endocrine abnormalities, and are therefore more likely to be macroadenomas. Based on autopsy studies, the prevalence of pituitary adenomas in the population is estimated to be about 14%, but the vast majority of these lesions are clinically silent microadenomas, pituitary incidentaloma. Pathogenesis. As with other neoplasms, pituitary adenomas are caused by mutations in cancer genes, which are most commonly acquired somatic mutations, but which may also be germline mutations associated with an inherited predisposition to pituitary neoplasms. Table 24.2. Activating G protein mutations are one of the most common alterations in pituitary adenomas. As described in Chapter 1, G proteins normally play a critical role in signal transduction, transmitting signals from particular cell surface receptors, e.g. GHRH receptor, to intracellular effectors, e.g. adenyl cyclase, which then generate second messengers, e.g. cyclic adenosine monophosphate CAMP. They are heterotrimeric proteins, composed of alpha subunits that bind guanine nucleotide and interact with cell surface receptors and intracellular effectors, figure 24, and beta and gamma subunits that non-covalently bind alpha subunits. GS is a stimulatory G protein with a pivotal role in signal transduction in several endocrine organs, including the pituitary. The alpha subunit of GS-alpha is encoded by the GNAS gene, located on chromosome 20q13. In the basal state, GS exists in an inactive state, with guanosine diphosphate GDP bound to the guanine nucleotide binding site of GS-alpha. On interaction with the ligand-bound cell surface receptor, GDP dissociates, and guanosine triphosphate GTP binds to GS-alpha, activating the G protein. The activation of GS-alpha generates CAMP, a potent mitogen for several types of endocrine cells, e.g. pituitary somatotrophs and corticotrophs, thyroid follicular cells, parathyroid cells. Normally, GS-alpha activation is transient because of an intrinsic GTPase activity in the alpha subunit, which hydrolyzes GTP into GDP. Approximately 40% of somatotroph cell adenomas bear somatic GNAS mutations that abrogate the GTPase activity of GS-alpha, leading to constitutive activation of GS-alpha, persistent generation of CAMP, and unchecked cellular proliferation. See Table 24.2. GNAS mutations have also been described in a minority of corticotroph adenomas. In contrast, GNAS mutations are absent in thyrotroph, lactotroph, and gonadotroph adenomas because their trophic hypothalamic release hormones act via other signaling pathways. Activating mutations of ubiquitin-specific protease 8 USP8 also occur in 30% to 60% of corticotroph adenomas. The encoded protein is an enzyme that removes ubiquitin residues from proteins like epidermal growth factor receptor, EGFR, protecting them from proteasome-dependent. Pituitary gland 1069, 4TT bilumers. GENET2YC alterations in pituitary. Protein function alpha subunit of stimulatory G protein, G-sulfa dubiquitinase, negative regulator of protein kinase A, leading to increased CAMP production transcription regulator. Gene oncogenic mutations, GNAS, somatic activating mutation, USP8, somatic activating mutation protein, kinase A, regulatory germline, inactivating mutations, subunit 1 alpha per Cotran A carny complex, Minone A germline inactivating mutations. Multiple endocrine, neoplasia type 1, germline inactivating mutations, MEN1-like syndrome, germline inactivating mutations, familial isolated pituitary. Adenoma syndrome, somatic activating mutation, germline inactivating mutation, agenetic alterations associated with familial or germline predisposition to pituitary adenomas. CDKN1BP27, KIP1 a negative cell cycle regulator. Receptor for aryl hydrocarbons and a ligand-activated transcription factor. Aryl hydrocarbon receptor. Interacting protein APA. Mitogenic signaling, cell growth and survival. MicroRNA processing, HRAs, DICER1A. Most commonly associated pituitary tumor, somatotroph adenoma. Corticotroph adenoma, somatotroph or lactotroph adenoma. Somatotroph, lactotroph or corticotroph adenoma. Corticotroph adenoma, somatotroph or lactotroph adenoma, especially in patients younger than 35 years of age. Pituitary carcinoma, pituitary blastoma, degradation, aberrant activation of USP8 thus enhances the activity of EGFR and other pro-growth signaling pathways in pituitary adenomas. Approximately 5% of pituitary adenomas are caused by germline loss of function mutations in genes such as MEN1, CDKN1B, Parkerone A, or AIP, see Table 24.2. Of ligand, GRH, TSH, PTH, receptor, ABG, PP, GTP, PP, GDP, PP, GDP, BGA mutation. Note, somatic mutations of these 4 genes are rarely encountered in sporadic pituitary adenomas. Morphology. The typical pituitary adenoma is soft and well circumscribed. Small adenomas may be confined to the sella turcica, but with expansion they frequently erode the sella turcica and anterior clinoid processes. Larger lesions may extend superiorly through the diaphragm sella into the suprasellar region, compressing the optic chiasm and adjacent structures, such as cranial nerves, figure 24. In as many as 30% of cases, the adenomas are not encapsulated and infiltrate neighboring tissues such as the cavernous and sphenoid sinuses, dura, and on occasion the brain itself. Such lesions are termed aggressive adenomas. Not unexpectedly, macroadenomas are more likely to be invasive and to have foci of hemorrhage and necrosis. Histologically, typical pituitary adenomas are composed of uniform monomorphic, polygonal cells arrayed in sheets or cords, PPP-GTP, adenyl cyclase A. CAMP, proliferation, hormone synthesis and secretion. Figure 24.3, G protein signaling and endocrine neoplasia. Mutations that lead to G protein hyperactivity are seen in a variety of endocrine neoplasms, including pituitary, thyroid, and parathyroid adenomas. G proteins composed of alpha and beta gamma subunits play a critical role in signal transduction, transmitting signals from cell surface receptors, GRH, TSH, or PTH receptor, to intracellular effectors, e.g., adenyl cyclase, which then generate second messengers, CAMP, cyclic adenosine monophosphate, that stimulate cellular responses. GDP, guanosine diphosphate, GTP, guanosine triphosphate, PI, inorganic phosphate, see Figure 24. 2 for other abbreviations. Figure 24.4, pituitary adenoma. This massive, non-functional adenoma has grown beyond the confines of the sella turcica, distorting the overlying brain. On average, non-functional adenomas are larger at time of diagnosis. Chapter 24. The endocrine system. Figure 24.5, pituitary adenoma. The monomorphism of these cells contrasts markedly with the mixture of cells seen in the normal anterior pituitary. Note also the absence of reticulin network. The supporting connective tissue, or reticulin, is sparse, accounting for the soft, gelatinous consistency of many of these tumors. The cellular monomorphism and the absence of a significant reticulin network distinguish pituitary adenomas from normal anterior pituitary parenchyma, Figure 24.5. Immunohistochemical stains for hormones and lineage-specific transcription factors are used to identify specific pituitary adenoma subtypes, see Table 24.1. Mitotic activity and expression of Ki67MIB1, a marker of cycling cells, are typically low in pituitary adenomas. Higher than normal rates of cell division are associated with more aggressive tumors. Clinical features. The signs and symptoms of pituitary adenomas are related to endocrine abnormalities and mass effects. The effects of excessive secretion of anterior pituitary hormones are mentioned later, when the specific types of pituitary adenoma are described. Local mass effects may be produced by any type of pituitary tumor. As mentioned earlier, these effects include radiographic abnormalities of the sella turcica, visual field abnormalities, signs and symptoms of elevated intracranial pressure, and occasionally hypopituitarism. Acute hemorrhage into an adenoma is sometimes associated with pituitary apoplexy, as noted earlier. The biologic behavior of a pituitary adenoma cannot always be reliably predicted from its histologic appearance. This has led some to suggest that the term adenoma, which implies a benign course, should be replaced by pituitary neuroendocrine tumor, a name that does not reflect any specific expectation about a tumor's behavior. The following is a description of the individual types of tumors. Lactotroph adenoma. Prolactin-secreting lactotroph adenomas are the most common type of hyperfunctioning pituitary adenoma, accounting for about 30% of clinically recognized cases. These lesions range from small microadenomas to large expansal tumors associated with symptomatic mass effects. 1070. Morphology. The large majority of lactotroph adenomas are composed of chromophobe cells with juxtanuclear localization of the transcription factor PIT -1. These are known as sparsely granulated lactotroph adenomas, Figure 24, 6a. Much rarer are the eosinophilic densely granulated lactotroph adenomas, characterized by diffuse cytoplasmic PIT1 localization. Figure 24. Prolactin can be demonstrated within cytoplasmic secretory granules with immunohistochemical stains, and estrogen receptor alpha or alpha is co-expressed along with PIT1, consistent with lactotroph differentiation. Lactotroph adenomas often undergo dystrophic calcification, ranging from isolated samoma bodies to extensive calcification, pituitary stone. Prolactin secretion by functioning adenomas is usually efficient and proportional in that serum prolactin concentrations tend to correlate with the size of the adenoma. B. Figure 24. Ultrastructural features of prolactinoma. A. Electron micrograph of a sparsely granulated prolactinoma. The tumor cells contain abundant granular endoplasmic reticulum, indicative of active protein synthesis, and small numbers of electron-dense secretory granules. B. Electron micrograph of a densely granulated growth hormone secreting adenoma. The tumor cells are filled with numerous large electron-dense secretory granules. Courtesy Dr. Eva Horvath, St. Michael's Hospital, Toronto, Ontario, Canada. Pituitary gland 1071. Clinical features: increased serum levels of prolactin or prolactinemia, cause amenorrhea, galactorrhea, loss of libido, and infertility. The diagnosis of an adenoma is made more readily in women than in men, especially between 20 and 40 years of age, because hyperprolactinemia disrupts the menstrual cycle. Lactotroph adenoma is the cause of almost 1/4 of cases of amenorrhea. In contrast, in men and older women, the hormonal manifestations may be subtle, allowing the tumors to reach considerable size, macroadenomas, before being detected clinically. Hyperprolactinemia may result from causes other than prolactin-secreting pituitary adenomas. Physiologic hyperprolactinemia occurs in pregnancy. Prolactin levels are also elevated by nipple stimulation, as occurs during suckling in lactating women and as a response to many types of stress. Pathologic hyperprolactinemia can also result from lactotroph hyperplasia caused by loss of dopamine-mediated inhibition of prolactin secretion. This may occur due to damage of the dopaminergic neurons of the hypothalamus or the pituitary stalk, e.g., due to head trauma or exposure to drugs that block dopamine receptors on lactotroph cells. Any supracellular mass, e.g., a pituitary adenoma, may disturb the inhibitory influence of the hypothalamus on prolactin secretion, resulting in hyperprolactinemia. Therefore, mild hyperprolactinemia in a person with a pituitary adenoma does not necessarily indicate a prolactin-secreting tumor. Other causes of hyperprolactinemia include renal failure and hypothyroidism. Lactotroph adenomas are treated by surgery or, more commonly, with bromocriptine, a dopamine receptor agonist that causes the lesions to diminish in size. Somatotroph adenoma. Growth hormone GH-secreting somatotroph adenomas are the second most common type of functioning pituitary adenoma and cause gigantism in children and acromegaly in adults. Somatotroph adenomas may be quite large by the time they come to clinical attention because the manifestations of excessive GH may be subtle. Morphology: histologically, pure somatotroph adenomas are also classified into densely granulated and sparsely granulated subtypes. Densely granulated somatotroph adenomas are composed of monomorphic, eosinophilic cells with granular cytoplasm, and A, large central nucleus with prominent nucleoli. The cells have diffuse, strong immunoreactivity for GH. In contrast, the sparsely granulated variants are composed of chromophobe cells with patchy, weak staining for GH and a characteristic paranuclear glossy inclusion known as a fibrous body composed of intermediate filaments that stain for cytokeratin. Bihormonal mammosomatotroph adenomas that synthesize GH and prolactin in the same cell are being increasingly recognized. Morphologically, most resemble densely granulated somatotroph adenomas, but have immunohistochemical reactivity for prolactin and GH. These are to be contrasted with mixed somatotroph-lactotroph adenomas, which have GH and prolactin expression in different cells. Clinical features: in contrast to corticotroph or gonadotroph adenomas, silent somatotroph adenomas are rare. Persistently elevated levels of GH stimulate the hepatic secretion of insulin, like growth factor -1 IGF-1, which causes many of the clinical manifestations. If a somatotroph adenoma appears in children before the epiphyses have closed, the elevated levels of GH and IGF-1 result in gigantism. This is characterized by a generalized increase in body size with disproportionately long arms and legs. If the levels of GH are increased after closure of the epiphyses, acromegaly develops. In this condition, growth is most conspicuous in skin and soft tissues, viscera, thyroid, heart, liver, and adrenals, and the bones of the face, hands, and feet. Bone density may increase hyperostosis in both the spine and the hips. Enlargement of the jaw results in its protrusion, prognathism, and broadening of the lower face. The feet and hands are enlarged, and the fingers become thickened and sausage-like. In most instances, gigantism is also accompanied by evidence of acromegaly. These changes may develop slowly over decades before being recognized, and hence the underlying adenoma may reach substantial size. GH excess can also be associated with a variety of other disturbances, including gonadal dysfunction, diabetes mellitus, generalized muscle weakness, hypertension, arthritis, congestive heart failure, and an increased risk of gastrointestinal cancers. The diagnosis relies on documenting elevated serum GH and IGF-1 levels. In addition, failure to suppress GH production in response to an oral load of glucose is one of the most sensitive tests for acromegaly. The causative pituitary adenoma can be removed surgically or treated by pharmacologic means. The latter includes somatostatin analogs. Recall that somatostatin inhibits pituitary GH secretion and GH receptor antagonists, which prevent hormone binding to target organs such as the liver. When effective control of high GH levels is achieved, the characteristic tissue overgrowth and related symptoms gradually recede, and the metabolic abnormalities improve. Overall, Sparsely granulated somatotroph adenomas tend to have a more aggressive course than densely granulated adenomas and may be less responsive to somatostatin analogs. Thus, accurate subtyping of somatotroph adenomas is of prognostic importance. Corticotroph adenoma. Excess production of ACH by functioning corticotroph adenomas leads to adrenal hypersecretion of cortisol and the development of hypercortisolism, also known as Cushing syndrome. Morphology. Corticotroph adenomas are usually microadenomas at the time of diagnosis. These tumors are most often basophilic densely granulated and occasionally chromophobic sparsely. Chapter 24, the endocrine system, granulated. Both variants stain positively with periodic acid shift PAZs because of the presence of carbohydrate in propionmelanocortin POMC, the precursor of ACH. Nuclear TPIT is also positive in the neoplastic cells, consistent with corticotroph lineage. A third uncommon variant, called Crook cell adenoma, is characterized by ring-like deposition of cytokeratin called Crook change. This variant has an aggressive natural history compared with other subtypes of corticotroph adenomas. Clinical features, the manifestations of Cushing syndrome, are discussed in more detail later with the diseases of the adrenal gland. The syndrome can be caused by a wide variety of conditions, in addition to ACH-producing pituitary tumors. When the hypercortisolism is due to excessive production of ACH by the pituitary, it is designated Cushing disease. Large destructive pituitary adenomas can develop in patients after surgical removal of the adrenal glands for treatment of Cushing syndrome. This condition, known as Nelson syndrome, occurs because of loss of the inhibitory effect of adrenal corticosteroids on a corticotroph microadenoma. Because the adrenals are absent in persons with Nelson syndrome, hypercortisolism does not develop. Patients present with mass effects due to the pituitary tumor, and there can be hyperpigmentation because melanotropin, which has trophic effects on melanocytes, is also derived from POMC. Other anterior pituitary tumors. Several less frequent types of pituitary adenoma also merit brief comment, see Table 24.1. Gonadotroph, LH-producing and FSH-producing adenomas can be difficult to recognize because they secrete small amounts of hormones that usually do not cause a recognizable clinical syndrome, i.e., most are non-functioning. Gonadotroph adenomas most frequently present in middle-aged men and women with neurologic symptoms, such as impaired vision, headaches, diplopia, or pituitary apoplexy. Pituitary hormone deficiencies can also be found, most commonly impaired secretion of LH, which causes decreased energy and libido in men due to reduced testosterone and amenorrhea in premenopausal women. The neoplastic cells express the common gonadotropin alpha subunit and the specific beta FSH and beta LH subunits. FSH is usually the predominant secreted hormone. Gonadotroph adenomas also usually express steroidogenic factor -1, SF-1, GATA2, and ER, transcription factors associated with normal gonadotroph differentiation. Thyrotroph, TSH-producing adenomas are uncommon, accounting for approximately 1% of pituitary adenomas. They are a rare cause of hyperthyroidism. Due to their shared lineage with lactotroph and somatotroph adenomas, these tumors also express PIT1. Pituitary adenomas may also secrete multiple hormones. Such plurihormonal adenomas are usually aggressive. Most are derived from cells of PIT1 expressing lineage. Null cell adenomas do not express any markers of hormonal or lineage differentiation. Not surprisingly, null cell adenomas typically present with symptoms stemming from mass effects. These lesions may also compromise the residual anterior pituitary and cause hypopituitarism, which may appear slowly due to gradual enlargement of the adenoma or abruptly because of acute intratumoral hemorrhage, pituitary apoplexy. Pituitary carcinoma is rare, accounting for less than 1% of pituitary tumors. The presence of craniospinal or systemic metastases is a sine qua non of a pituitary carcinoma. Most pituitary carcinomas are functional, with prolactin and ACH being the most commonly secreted products. Metastases usually appear late in the course, following multiple local recurrences. Pituitary blastoma is an entity that occurs in children, typically younger than 2 years of age, who carry germline mutations of DICER1, the gene encoding a microRNA processing protein. Morphologically, these tumors are composed of immature blastoma-like cells, so-called small round blue cells, and rosette-like formations resembling the primitive Rathke epithelium from which the pituitary develops. Pituitary blastoma presents with signs and symptoms of Cushing disease. These children also develop primitive blastoma-like neoplasms in other organs, most commonly pleuropulmonary blastoma. Key concepts: hyperpituitarism. The most common cause of hyperpituitarism is an anterior lobe pituitary adenoma. Pituitary adenomas can be macroadenomas greater than 1 centimeter in diameter or microadenomas. Functioning adenomas are associated with distinct endocrine signs and symptoms, while non-functioning silent adenomas typically present with mass effects, including visual disturbances. Lactotroph adenomas secrete prolactin and can present with amenorrhea, galactorrhea, loss of libido, and infertility. Somatotroph adenomas secrete GH and present with gigantism in children and acromegaly in adults, impaired glucose tolerance, and diabetes mellitus. Corticotroph adenomas secrete TAKE and present with Cushing syndrome and hyperpigmentation, the two distinctive morphologic features of most adenomas. Are there cellular monomorphism and absence of a reticulin? Network: hypopituitarism. Hypopituitarism refers to decreased secretion of pituitary hormones, which can result from diseases of the hypothalamus or of the pituitary. Hypofunction of the anterior pituitary occurs when approximately 75% of the parenchyma is lost or absent. When accompanied by evidence of posterior pituitary dysfunction in the form of diabetes insipidus, see later, hypopituitarism is almost always of hypothalamic origin. Most cases of hypopituitarism arise from destructive processes involving the anterior pituitary, as follows: 1072. Pituitary gland 1073. Tumors and other mass lesions. Pituitary adenomas. Other benign tumors arising within the sella, primary and metastatic malignancies, and cysts can cause hypopituitarism. Any mass lesion in the sella can cause damage by exerting pressure on adjacent normal pituitary cells. Traumatic brain injury and subarachnoid hemorrhage are among the most common causes of pituitary hypofunction. Pituitary surgery or radiation. Surgical excision of a pituitary adenoma may inadvertently include the non-adenomatous pituitary. Radiation of the pituitary, used to prevent regrowth of residual tumor after surgery, can damage the non-adenomatous pituitary. Pituitary apoplexy. As mentioned earlier, this is caused by a sudden hemorrhage into the pituitary gland, often occurring into a pituitary adenoma. In its most dramatic presentation, apoplexy causes the abrupt onset of excruciating headache, diplopia due to pressure on the oculomotor nerves, and acute hypopituitarism. In severe cases, it can cause cardiovascular collapse, loss of consciousness, and even sudden death. The combination of mass effect from the hemorrhage and acute hypopituitarism makes pituitary apoplexy a neurosurgical emergency. Ischemic necrosis of the pituitary Sheehan syndrome, also known as postpartum necrosis, is the most common form of ischemic necrosis of the anterior pituitary. During pregnancy, the anterior pituitary enlarges to almost twice its normal size. This physiologic expansion of the gland is not accompanied by an increase in blood supply from the low-pressure venous system. Hence, there is relative hypoxia. Any further reduction in blood supply caused by obstetric hemorrhage or shock may precipitate infarction of the anterior lobe. Because the posterior pituitary is supplied directly from arterial branches, it is much less susceptible to ischemic injury and is therefore usually unaffected. Pituitary necrosis may also be encountered in disseminated intravascular coagulation and, less commonly, in sickle cell anemia, elevated intracranial pressure, traumatic injury, and shock of any origin. Whatever the pathogenesis, the ischemic area is resorbed and replaced by a nubbin of fibrous tissue attached to the wall of an empty cella. Rathke cleft cyst. These cysts, lined by ciliated cuboidal epithelium with occasional goblet cells and anterior pituitary cells, can accumulate proteinaceous fluid and expand, compromising the normal gland. Empty cella syndrome, any condition or treatment that destroys part or all of the pituitary gland, such as ablation of the pituitary by surgery or radiation, can result in an empty cella and the empty cella syndrome. There are two types. One, in a primary empty cella. A defect in the diaphragma cella allows the arachnoid mater and cerebrospinal fluid to herniate into the cella, expanding the cella and compressing the pituitary. Classically, this occurs in obese women with a history of multiple pregnancies. Affected individuals often present with visual field defects, and occasionally with endocrine anomalies, such as hyperprolactinemia, due to interruption of inhibitory hypothalamic inputs. Sometimes the loss of functioning parenchyma is sufficient to produce hypopituitarism. 2. In secondary empty cella, a mass, such as a pituitary adenoma, enlarges the cella and is then either surgically removed or undergoes infarction, leading to loss of pituitary function. Hypothalamic lesions, as mentioned earlier. Hypothalamic lesions can also affect the pituitary by causing a deficiency of pituitary hormone releasing factors. In contrast to diseases that involve the pituitary directly, hypothalamic abnormalities can also diminish the secretion of ADH, resulting in diabetes insipidus, discussed later. Hypothalamic lesions that cause hypopituitarism include tumors, which may be benign, e.g. craniopharyngioma, or malignant. Most of the latter are metastases from tumors such as breast and lung carcinoma. Hypothalamic insufficiency may also appear following irradiation of the brain. Inflammatory disorders and infections, such as sarcoidosis or tuberculous meningitis, can involve the hypothalamus and cause deficiencies of anterior pituitary hormones and diabetes insipidus. Genetic defects. Congenital deficiency of transcription factors required for normal pituitary function is a rare cause of hypopituitarism. For example, mutation of the pituitary-specific gene, PIT1, results in combined pituitary hormone deficiency, characterized by deficiencies of GH, prolactin, and TSH. The clinical manifestations of anterior pituitary hypofunction vary depending on the specific hormones that are lacking. Children can develop growth failure pituitary dwarfism due to growth hormone deficiency. Gonadotropin LH and FSH deficiency leads to amenorrhea and infertility in women, and decreased libido, impotence, and loss of pubic and axillary hair in men. TSH and ACTH deficiencies result in symptoms of hypothyroidism and hypoadrenalism, respectively, and are discussed later in this chapter. Prolactin deficiency results in failure of postpartum lactation. The anterior pituitary is also a rich source of melanotropins, also known as melanocyte-stimulating hormone, synthesized from the same precursor molecule that produces ACTH. Therefore, one of the manifestations of hypopituitarism includes pallor due to a loss of stimulatory effects on melanocytes. Posterior pituitary syndromes. The clinically relevant posterior pituitary syndromes involve ADH and include diabetes insipidus and syndrome of inappropriate secretion of ADH. Diabetes insipidus. ADH deficiency causes diabetes insipidus, a condition characterized by excessive urination polyuria due to an inability of the kidney to resorb water properly from the urine. Diabetes insipidus can occur in a variety of conditions, including head trauma, tumors, inflammatory disorders of the hypothalamus and pituitary, and surgical complications. Rarely, diabetes insipidus has a genetic basis, either because of autosomal dominant mutations of the arginine vasopressin AVP gene or mutations of arginine vasopressin. Chapter 24. The endocrine system. AVPR2, an X-linked condition that usually presents in young boys. Diabetes insipidus from ADH deficiency is designated as central to differentiate it from nephrogenic diabetes insipidus, which is a result of renal tubular unresponsiveness to circulating ADH. The clinical manifestations of these two disorders are similar and include the excretion of large volumes of dilute urine with a lower than normal specific gravity. Serum sodium and osmolality are increased by the excessive renal loss of free water, resulting in thirst and polydipsia. Patients who can drink water generally compensate for the urinary losses, but patients who are obtunded, bedridden, or otherwise limited in their ability to obtain water may develop life-threatening dehydration. Syndrome of inappropriate ADH syad secretion. ADH excess causes over-resorption of free water, resulting in hyponatremia. The most frequent causes of syad are the secretion of ectopic ADH by malignant neoplasms, particularly small cell carcinoma of the lung, drugs that increase ADH secretion, and a variety of central nervous system disorders, including infections and trauma. The clinical manifestations of SIAD are dominated by hyponatremia, cerebral edema, and resultant neurologic dysfunction. Although total body water is increased, blood volume remains normal, and peripheral edema does not develop. Figure 24.7, adamantinomatous craniopharyngioma, demonstrating characteristic compact, lamellar wet keratin right half of photomicrograph, and cords of squamous epithelium with peripheral palisade. Courtesy Dr. Charles Eberhardt, Department of Pathology, Johns Hopkins University, Baltimore, MD. Hypothalamic suprasellar tumors. Neoplasms in this location may induce hypofunction or